Hey everyone, welcome to episode number 2 of Pain Consultants USA podcast. Today, Dr. Bonner and I are going to have a conversation about lumbar disc herniations, how to self-diagnose and manage without seeing a physician. How you doing
I'm
today,
very
Dr.
good,
Bonner?
thank you. How are you?
Good, good. Looking forward to our
Yeah.
conversation today. So, why don't you start with just kind of telling patients what is a lumbar disc, um, and how we define it
Yeah,
and stuff like
so
that.
if you have a problem with your lumbar disc, or if you've been told that you have a problem with a disc herniation, something of that sort, you need to understand what the disc is exactly first. And so I have this model here of the lumbar spine, and this shows us here there's 5 lumbar vertebral bodies. These are the bones in the spine, okay? And in between each of those bones is a disc, okay? So this like kind of clear gelish looking segment, these are each the discs that connect the different bones in the spine. And we can't see it on this angle, but if we were to cut through the disc and look down at it, you can see that there's really 2 main parts of the disc. One is the outer ring, which is called the annulus fibrosus, and that's made up of like some connective tissue. And then there's an inner area that's more of like a jelly-like substance, and that's called the nucleus pulposus. So sometimes we talk about the disc kind of looking like a jelly donut if we were to cut right through it, just like in this manner. And so the jelly is kind of on the inside, and then there's an outer ring of connective tissue on the outside. And these discs are important because they allow a lot of the motion that occurs in the spine. So if we just had bone all the way down the spine would be pretty much immobile because bone is very kind of inflexible. But the discs allow for lots of movement. Now, this model is not flexible, so I can't really move it, but the discs do allow for lots of movement, and most of the movement that occurs in your spine probably occurs because the discs are there to allow it, along with the joints in the posterior part of the spine. Uh, so that's pretty much a basic overview of what the disc looks like, and then what the disc function to do for us. Um, so I guess maybe next, do we want to get into why that is important?
Yeah, I mean, just like Dr. Bonner highlighted, right? Movement, all types of movement go through the lumbar spine, whether you're bending at the waist, forward, backwards, rotating with such activities as just bending over to pick up something on the ground versus golfing or more high level activities such as weightlifting, powerlifting, deadlifts, squatting. A lot of force goes through these areas. And again, whether you're a high level athlete or just somebody, a weekend warrior, as they call them, a lot of people are going to end up having issues with their discs and their low back. So, and this spans many age groups. We could have people in their early 20s, 30s, 40s, and well beyond that. So, unfortunately, it's very common. It's going to affect lots of people. If it hasn't affected yourself, you're lucky, but you'll probably know somebody that it has. So, the more educated you are for yourself, or even a friend or a family member, I think it can only help with treatment and kind of long-term outcomes.
Yeah, I think that's really important because I think like we're going to repeat ourselves over and over, but the more a patient understands what the problem is and why the problem happened, the more likely they are to be able to help start healing that problem and start to feel better. And so it's all about education. If the patient's educated, they are going to have the power to help themselves get better. So, you know, if you have a disc problem, you might be wondering, well, what happened? Why did I get that injury to the disc? Um, and most commonly for the lumbar spine, the injury to the disc occurs through repetitive injury over time. So, although a patient may feel that injury at one specific time, that injury really developed over a long period of time, kind of repetitive loading of the disc through what we call flexion or bending over at the waist and twisting. So it puts a lot of stress on the outer ring of the disc and eventually leads to tearing of that ring when you repetitively bend over and repetitively twist, or kind of do both at the same time. And so if you're in a job where you might be doing that over and over again, you're definitely at risk for more lumbar spine disc injury. If you're weightlifting with poor form, doing something like a deadlift where you're kind of bending over frequently, you're definitely at a higher risk of injury to the lumbar spine. So anything where you tend to be kind of bending over or twisting the low back puts you at a risk of injury to the disc.
Yeah, I think it's important just to kind of highlight the pressures the discs experience as well, right? So I talk with a lot of my patients about, when you're laying flat, right? Least amount of pressure going through a disc technically. Standing, you have about your body weight, right? And then sitting, twice as much pressure through the disc because of that flexion. Standing and bending at the waist is obviously going to put a lot more pressure through there. And then any forward flexion at the waist and then a rotation like you're talking about. So like an example would be, I hear a lot of times with patients where they're getting groceries out of their back seat, if they're standing, bend forward, and then with their feet planted, they try to get the groceries out of the car, so they might rotate. That's one mechanism that I hear quite frequently as far as feeling a pain in the back. And like you said, these are repetitive injuries for the most part. And so when it actually finally occurs and you're feeling it, this is built up over time. Looking back, you might have had episodes where you had some back pain that would go away after a few days or a week, and then everything was back to normal. Well, what that back pain might have been is a little injury or micro injury to the disc itself in that outer part of that disc that you highlighted, that annulus.
Yeah, and so I guess that's where we can kind of talk about a couple different types of pain that might be related to a disc injury. So if we just have an injury where the inner part of the disc, the jelly-like nucleus pulposus, kind of pushes out into the annulus, we call that internal disc disruption. And that can happen slowly over time, like we talked about. And that tends to cause more pain that's what we call axial, or just stays in the low back and doesn't tend to radiate anywhere. Now, if that injury to the disc becomes so severe that the jelly-like substance can then push out of the annulus fibrosus and into the spinal canal, so that would be into this area where the spinal nerves travel or the spinal cord travels, then the disc can sometimes push on a nerve and cause pain radiating down the leg. And that's what many people refer to as sciatica or a pinched nerve or other things like that. And if you didn't see that quite well, let me just try to show that again. And for those who are listening on the podcast, I would suggest going to our YouTube page to see the video. But basically, the herniation would push into the area where the spinal cord and the spinal nerves are traveling. And then we actually have on this model, there's a red area where they want to show that a disc is pushing onto the nerve and pressing on the nerve and causing pain, and the pain from that would then shoot down the leg into the distribution of that nerve.
Yeah, and I think just to add to that, the location of the disc herniation is going to be important when we're trying to figure out what the cause of our leg pain is. So again, on this little model, like Dr. Bonner highlighted, right? So if you have a disc herniation in the center, pushing back into where the nerves pass through, almost like a tunnel, right? Most patients will have discomfort with sitting, feel pretty good standing, versus on that model and the same one here with the little disc herniation, that red little bump there, kind of hitting the nerve as it exits the spine. Pain is usually could be more with standing, side bending, and improves with sitting. So these are some keys to kind of listening to your own body with regards to what kind of aggravates pain, what makes it better, that can kind of help to tease out what might be going on.
Okay, so we've reviewed the anatomy of the disc. We've reviewed the types of different injuries that can happen with the disc and the types of pain it can cause, and that pain really being either just in the back or pain that's in one leg or even sometimes both legs from really large disc herniations that are pushing into the center of the canal. And so what does a patient really feel when they present with one of those issues? Well, we hear all kinds of stories. So like we said, it can be an acute story. Oh, I bent over and twisted and I picked something heavy up and all of a sudden my back hurt. And then within a day or two, the pain was shooting down my leg. Or it can be a bit of a gradual story. You know, maybe the patient doesn't realize at any point doing something in particular that hurt the back, but all of a sudden they woke up one day, pain started in the back, it slowly developed to getting worse and may or may not radiate down the leg. So we hear both in terms of stories from the patient. And go ahead, yeah.
Yeah, and just to add to that, sorry, sometimes you don't even necessarily have to have much back pain.
Very true.
And this is where I think a lot of times people get confused, more so like providers. So when patients see the doctor and they're having just some outer hip pain or pain going on the outside part of their leg above their knee and no back pain, oftentimes that pushes people down the road of, one treatment, whether it be hip or muscle related, rather than the actual underlying cause.
I think I see that all the time, where I see patients who have had MRIs of parts of their legs looking for something causing a pain in their lower leg, like just past the knee on the outside of the leg, or like you said, the hip region, and they come see me, and my assessment is really that everything is coming from the back, and it's all kind of creating other problems that are just kind of secondary to the back problem. And I think that that's where a good specialist can really come into play and help someone figure out this issue, because we're more aware of kind of where these pains from the different pinched nerves and things can travel.
Yeah, and kind of speaking about today's topic, how a lot of this stuff, patients, you can self-diagnose as long as you're educated enough on it. So again, if you start to develop some discomfort into the leg, whether it be on the outside part of the thigh, not going below the knee, which is a very common area, or discomfort going down the back of the leg into the calf, or even into the front of the thigh or shin, if it's pain that, first of all, you don't know why it started, it's not going away after a few days, whether you rest, take it easy, avoid any aggravating activity, but then you really have to get in tune with your body and start kind of listening to and understanding, okay, well, what makes this better? What makes this worse? Because based on that, oftentimes you can kind of figure out what's going on. So again, it's, where's the pain? And then, okay, what's making it better? What's making it worse? Are some of the key things needed to be able to successfully kind of identify your issue before you even see your family doctor, a spine specialist, an orthopedist, or a physical
Yeah,
therapist?
so let's go a little bit more into that because you brought it up. So, what makes it better? What makes it worse? So, what are the most common things that we look at to see what makes it better or makes it worse is really range of motion of the spine. So, is it worse when you bend over or lean backwards? Commonly, with one of these disc issues, it's very commonly that bending over causes more pain. And that maybe leaning backwards, or not necessarily leaning backwards, but kind of laying on your stomach and arching that way may feel much better in terms of the pain. So if a patient is thinking, do I have a disc herniation or do I have a painful disc in my low back? I would recommend the first thing to assess is, does it feel better or worse with bending over? And does it feel better or worse with laying down in your stomach? And maybe not just laying down in your stomach, but then kind of slowly arching your back up into what might be like a cobra yoga pose and seeing if that helps. Um, and that gives us a good idea of what is causing the stress on the tissue and what kind of we might be able to use to help treat the problem. Is there any other moves you'd
It,
like to use to do that?
well, I think the exact opposite also applies. So if the pain comes on with activity, walking, standing, and it improves with sitting, right? So, and bending forward at the waist, almost the exact opposite. Again, that can clue us in as far as where the pain or where the disc issue might be. Um, I know we'll talk about this in more detail on further podcasts, but age is also important, right? So, just briefly, if you're a 30 or 40-year-old individual and you have discomfort going down the leg, it's worse with walking, standing, improves with sitting, well, that might be where that disc herniation is more off to one side or the other, like I mentioned before, versus if you're 65, 75, 80, and you have pain that won't go away when you're standing or walking, improves with sitting, that then you start thinking more of like a stenosis picture, which we'll talk about more. But again, I mean, standing versus sitting, I mean, it can help us
Yeah.
out quite a bit. And one thing we should talk about is, well, okay, what kind of pain are you feeling in the leg? Right. So some people think, well, for it to be nerve pain, it has to be burning, it has to be numb or tingly. Um, they need to feel little creepy crawlers going down their leg. Stabbing, shooting type pain is often what we hear this described as. But oftentimes, it's just a deep toothache. And that's why it oftentimes gets, I think, in my opinion, confused with muscle pain, because it feels like a
Yeah.
deep toothache. That's what the kind of referred pain you
That's
get.
exactly what I felt when I had this problem in my leg. Was I felt like I had a really deep toothache in the outside part of my lower leg and I didn't know where it was coming from. And then I did another like bend over type movement and all of a sudden the pain in that area just like exploded. And so you can probably, I can probably go back to what we were talking about earlier in the progression of a disc herniation, but, I probably had some bulging of the disc related to the internal disc disruption. And then with kind of more repetitive bending and twisting, I then kind of really herniated the disc outright and then really created a lot of pain, like I was just describing. And so, and it changes. So it was deep and achy, and then it was burny, and then sometimes it's still stiff, and so it changes all around. And so don't be surprised if you're a patient listening to this and you say, well, sometimes it's this and sometimes it's that. That's very normal. It's not going to be the same thing all the time. The other thing that I learned, I think, from having a similar issue is sometimes it's really hard to characterize. Sometimes we might get frustrated with a patient, like, where is the pain and what does it feel like? And they're like, well, I don't know. It's kind of in this area. It's kind of in that area. Sometimes it's here. Sometimes it's there. Sometimes it feels like this. Sometimes it feels like that. Pain is very hard to kind of pin down. And that sometimes is what makes our job so difficult. So anything a patient can do to kind of keep track of how it feels, what makes it feel that way, and what makes it feel better is very useful in helping us try to figure out how to solve the problem and figure out what's causing the problem, really.
Yeah, and I mean, I would say too, if this is something that you've already been dealing with, or you have pain in the leg and it's not getting better, and you're wondering if you do have a herniated disc, right? So some of the common things I see as far as misdiagnosis, right? I mean, you hear a lot of people being diagnosed with like a IT band syndrome,
Greater
right?
trochanteric bursitis is one that I would say I see people say they have all the time, and then they see me, and I think they have more of a pinched nerve problem in their back.
Yeah.
Mm-hmm.
Piriformis syndrome is another one I see with more gluteal pain. The nerves in the low back, like Dr. Bonner showed on that model before, each nerve travels to a certain area. So there's 5 nerves in the lumbar spine. So L1 travels to the groin. L2 is kind of mid thigh. L3 comes to the front of the thigh, above the knee. L4, oftentimes you'll feel more on like the inside part of your shin. Typically, we say L5 down the outer side of the leg. That's where a lot of people with these greater trochanteric bursitis syndromes or IT band oftentimes is like an L5. S1, which is right below the lumbar spine, but commonly affected with disc issues all the way at the lowest level of the back, will be kind of more down the back of the leg typically. So that's also important. Where in the leg is it? And that can kind of clue you in too, as far as what level, if you want to go to that kind of second level thinking.
So, and once we have a good idea of kind of what the problem might be and what makes it better and what makes it worse, I think then we just try to use that to our advantage. So, one of the most important things that I tell people, and I think is really one of the most important things for treating yourself, is avoiding aggravating the problem. So if it hurts when you sit, don't spend a lot of time sitting, or get up frequently if you're sitting. If it hurts when you run, well, either change the way that you're working out, maybe no running, maybe change to walking or an elliptical, or you need to alter the things you do so that you're not just constantly aggravating the problem, because you're making it more likely to persist if you don't kind of let the problem get better itself. So just avoid the aggravation of the issue.
And I would say sometimes that's the most
It
difficult
is, I
thing for
agree. Yeah.
patients, right? Especially active people. I mean, you don't even have to be that active, but if you're sitting for work or you have a long drive, you got to figure out ways to modify this, because if you do have what Dr. Bonner's described as like a directional preference, right? So if sitting makes it worse, well then flexion sitting is not good, standing is better. So there's your directional preference. You like extension or straightening of the low back. Then when these issues are new and acute, you have to live in your directional preference. But again, the outcomes are going to take a while. So if you're all about immediate gratification, this could be very difficult. I mean, patience is required for this.
I mean, and I can speak to that, living in your directional preference. I mean, I spoke about how I developed this type of pain before, and when I had the problem, every hour I set a timer. Every hour when I was at work, I would go find a place to go lay on my stomach and then extend my spine slightly, so in that like cobra yoga position, because that, to me, that was what relieved the pain and the symptoms. And presumably relieve the pressure on the nerve that was causing the pain. And um, so I spent a lot of time getting to that position and kind of using that as my medication. Instead of taking a pill, I would just every hour or whenever I was having a worsening of the pain, I would go find that position and then get to that position, and it would relieve the pain. And so I try to tell patients to do the same thing. If it's sitting down and bending over that feels good, use that to your advantage. If it's laying on your stomach, use that to your advantage. You just have to find a place to work that into your day and make it happen.
And as silly as it sounds, when you get home from work, if you have to sit at work, you don't sit
Yep.
when you get home, especially if sitting causes your pain. You eat dinner standing up. If you're watching TV, you're in that position on your belly watching TV or standing. You go out to dinner, you sit at the bar, or whoever you're with sits, you stand at the bar, you eat. Um, those types of modifications, as silly as it sounds, can make a big
Yeah, and
difference.
we can go back to what we talked about in the beginning with the structure of the disc. So um, I don't have necessarily a disc to show, but I can show the top of this. And let me get a good picture of that right there. Okay. So if the disc is here, okay, uh, the posterior part of the disc is this part that faces towards the spinal canal. Okay. And every time you bend over, you're putting more pressure on that area because it stresses those tissues. And so the gel that's in the center of the disc is more likely to push out and press on these nerves, and also to irritate the posterior part of the annulus layer, which can be painful also. And so what it does every time you sit down or get in that bad position is the disc can slowly start to push back out. So say you've spent an hour laying down on your stomach and your back feels much better. Well, what we assume happens is that that disc has kind of reabsorbed back towards the center of the disc. But then if you spend an hour sitting, that disc can slowly push back out. It's a phenomenon that's been called creep, because the disc kind of slowly creeps back out. If you do repetitive bending and twisting, you'll get the same thing but much quicker. But even just sitting in a position, the disc can slowly, the gel layer in the center can slowly start to creep back out the back of the disc and then press on the nerve again and give you those symptoms. So just like Dr. Connor said, it's very important that you don't spend prolonged periods of time in that bad position for you, because probably partly because of that creep phenomenon. When you have a disc herniation, you don't want that jelly layer to kind of start pushing back out and irritating the nerve. So whenever you can, stay away from your bad positions, and also get to the good positions that feel much better for you, because that's probably a position where the disc is in a better position for you and not pressing on that nerve.
And we've talked a lot about the evils of sitting with this issue, but can you show the whole model for a second,
Yeah.
Dr. Bonner, including like the lordosis there, right? So when you do have to sit, a couple strategies that have seemed to work for me is, first of all, your hips should be above your knees. So it's always typical, a bucket type seat. You want to kind of sit up higher. And the other thing is, a lot of people use like a lumbar roll in their low back. But I find that when you're sitting in a car, if you actually put like a normal towel in the bucket part of the seat, kind of fold it up in a rectangle, when you sit down, you're sitting kind of more on like the bones of the butt, what they call their ischial tuberosity, and it will actually rotate your pelvis forward. And then it'll add a little bit of lumbar kind of contour or roll to your low back naturally.
The model doesn't have much of a curve in it, but there should be a bit of a curve like this in your lumbar spine. And when you get into that curvature, that's what should feel good for your disc typically. Now, if you have a problem with the disc, typically when you sit, you lose that curvature, and thus it causes more pain for most people who have disc problems when they sit for a while.
Yeah, exactly. So maintaining that curvature is through those two little tips that I just mentioned is almost a way of standing or arching backwards while you have to sit.
Exactly.
So another way to get to work with less pain, and then when you're at work, you stand.
Yeah, so they do have those adjustable desks now too, where people can kind of sit down for a little bit and then stand up for a little bit, or you can just get a standing desk and just stand most of the time. Um, but there's different ways to do it now. I definitely recommend that patients get up every 15 minutes or so and just take a walk around the room. That can often be very helpful.
And if you do this, a pretty cool experience will happen, right? You'll actually feel less pain in your leg. You can actually kind of feel the pain come out of your leg. That's the medical community has kind of coined that centralization, right? So the pain comes out of the leg, might go more into the buttock or low back area with these extension-based activities or whatever feels better based on your directional preference. And if you get this centralization experience, that's actually a good sign that with time and appropriate treatment, conservative treatment, that this is going to continue to improve to the point where you can potentially avoid, unnecessary medications, procedures, surgeries,
Yeah.
those types of
And we
things.
want you to do that as soon as possible. So if you're listening to this and you feel like you just hurt your back, you might want to try to get in these positions right away and figure out what makes you feel better, and then use that to your advantage immediately. So if laying on your stomach feels good and you just hurt yourself, you want to kind of maintain that position quite a bit throughout the day, especially whenever you're getting worse and worse pain.
And there's always caveats to these things, and there's a subset of patients, and it's small, but if your disc herniation is in the exact wrong spot, hitting part of your nerve called your dorsal root ganglion, which we can show you on a model. It can be, here, I'll show you here on this model, if you can see, right? So this is the back part. These bones are what you feel when you touch the center of your back. Again, center with all your nerves passing through, and each nerve exits individually. If you can make out this little kind of ball here at the end, this is actually where a bunch of the cells that make up these neurons, which are the nerves that come out of the back, a lot of the control system is found in here. So if a disc is touching directly on that, that can cause severe pain. Oftentimes, those patients can't find a comfortable position. You're getting a lot of burning pain with that, the typical kind of nerve pain that we think of. If you can't get a position of comfort, obviously you should talk to your doctor sooner, but it's pretty rare.
Great. So, we also have a few other tips that have been recommended for people with painful disc problems. We've talked about avoiding bending and twisting, or specifically really whatever has caused your pain, whatever movement has caused your pain. Another thing to add to that is to especially avoid those movements in the morning. For certain reasons, your discs are actually swollen with fluid in the morning, and so it takes probably a half hour to an hour for some of that fluid to come out of the disc. And while that fluid is in the disc, it's more prone to injury because the pressures are higher within the disc. So in the morning, you really especially want to avoid bending over and twisting, and you really want to avoid any specific spine exercise, especially if it involves flexion of the spine or bending over. So any kind of sit-ups or crunches, those are bad exercises to be doing within the first hour of getting out of bed. I don't know if you have anything to add to that, Dr. Connor.
No, I mean, I completely agree with that. And you'll talking to patients, I mean, you'll hear that where in the morning back is real stiff. There's some discomfort. You get moving, feels a little better. Some people who actually will go on an inversion table will have a similar experience, right? Inversion table, and they're pretty popular. You're completely upside down. You're using gravity and your body weight to actually kind of distract the disc, and with the concept of it kind of again kind of creeping back into the center. When some of my patients get off an inversion table, I mean, pain in the leg is gone, but they have
Yeah.
severe
Yeah.
pain in the back
Yeah.
with a lot of stiffness, and that's why.
Yeah.
What do you say, or what's your feelings on inversion
Yeah.
tables?
I don't have too strong of an opinion. I think that if it makes you feel good and doesn't seem to be causing issues, then it's probably okay. But I think the relief that we tend to see is pretty temporary. Now, for some people, it's very important to get that temporary relief, but I don't like people to necessarily make a complete habit out of it. I don't know how you think about that.
Yeah, I mean, acutely, I think there's probably
Mm-hmm.
more of a role. Now, again, this is strictly speaking for disc herniations. Down the road, if you're dealing with this for a few months,
Yeah.
not really sure. I tell patients if something happens to them and they have a friend with one, I would go borrow theirs or use theirs for a couple weeks or so rather than go
Yeah.
buy your own, because oftentimes once you get through that acute episode, things you don't
Yeah.
necessarily need them. And that goes, I mean, there's a lot of other products out there with, what are your thoughts on the belts and different compressive devices around the
Sure.
abdomen?
Um, So a few other tips that we had just before we wrap things up. We mentioned kind of using a pillow or a towel when sitting. That can definitely help. Another tip is taking a walk. If you have a disc problem, you can often feel much better with taking a walk. And typically, you need to take a fast walk. So you can't just take a light stroll. You need to walk quickly with a large arm swing. And by utilizing the muscles that you do to walk like that, it actually can reduce torque on the spine, reduce muscle activity on the spine, and reduce loading of the spine, which will subsequently make you feel better and reduce your symptoms. So especially if you're having trouble while sitting, get up and go take a quick walk and see if that really helps. And you can incorporate that into your day for multiple kind of 5 to 10 minute walks to kind of reduce symptoms, just like you can incorporate finding your comfortable position. And the other tip that goes along with that is if just walking doesn't work, you can also try putting about 10 to 20 pounds of weight in the bottom of a backpack. And that can also help kind of reduce muscle activity in the spine and thus reduce the load on the spine and the pain.
Yeah, and I find along those lines, and we briefly talked about it before. So, say you're a runner and you're having this pain. Well, you really do have to shut it down
Yeah.
for a little while. And my rule of thumb is, pain free in the leg for at least a month before you begin to reintegrate back into running. Um, but I find a good transition is that of using the elliptical. So if you have one at home or at the gym, if the elliptical is kind of in a neutral position, so not inclined or declined, to avoid excessive, flexion or extension of the back, and you're doing that at, a medium pace. Oftentimes, that's a good progression from this brisk walking to progress to running
Yeah.
again.
I think that's great. I think like we've mentioned before, that exercise is really complicated. So, a lot of patients who develop these problems might be very intense exercisers. And if you develop a problem like this, you really have to kind of evaluate what you're doing that might be causing this problem, and then really adjust the exercise program to make it better. So that's sometimes where a really experienced physical medicine physician or a physical therapist with a lot of experience with these issues can kind of help someone adjust the exercise program so that it won't be causing pain. We might be experiencing some audio issues here. Can you
I would
hear me
agree
now?
with that.
Yeah.
Exercise can also be used as medicine, and that's really the focus of what we're about here, is using exercise in a appropriate way to help kind of guide treatment and use it as medicine. A structured physical medicine approach to a lot of these issues can oftentimes really help. You could avoid medications, injections, surgery. So again, exercise is medicine. We can use it that way, but again, you need to. I think that's where our role is. We're hoping to be able to educate you guys and gals about this stuff to hopefully, empower yourselves to be able to treat yourselves. Today I think Dr. Bonner and I talked quite a bit about figuring out what's causing your leg pain. The symptoms, what to look out for, especially, we talked a lot about what makes it better or worse. So that's something that you really need to pay attention to. And then again, keep it simple. If it makes it worse, you avoid it. It's as simple as that sounds. I mean, you do that for a while, you should see improvements. We will have our podcast, this audio up, available for review later. We'll have a transcript, so you could always go back to reference this, whether you're having an issue or one of your loved ones. Future podcasts and videos, we will talk about, if the self-treatment doesn't work, we'll get into more of the advanced medical approach to treating this stuff as well. But I want to thank you guys for watching today. And if you have any questions, feel free to visit our website. And we look forward to talking to you guys again in the near future.
Great.